And we move now to Dr. Miroslav Ilic from Serbia, who is going to speak about the true restrictive laparoscopic gastric sleeve, J-shape, as a first choice in bariatric surgery. I think the shape of the sleeve is something is crucial in our mind. I keep taking picture of each specimen I take out of the patient to get an idea of which is the best. And I wonder very much what Professor Miroslav idea are regarding this topic. Thank you, Miroslav. There is no audio. Activate your audio.
Dear Professor Anvisani, thank you very much for your nice presentation and for you all colleagues and participants. Thank you also for invitation from Easy Search. I have a good experience last 3 years with Easy Search devices. So I would like to comment on some notes about is it gastric sleeve? Are we doing a good gastric sleeve surgery? And all our younger surgeons also came in operating theater, but also in the beginning of our of bariatric history, let's say, most of gastric sleeve are not doing well. So I would like to just comment a little bit about this shape of a gastric sleeve. So we are going next slide, okay. Okay. When we look some BOSS randomized planet trial, among patients with morbid obesity, there is no significant difference in excess body mass, between laparoscopic sleeve gastrectomy and laparoscopic Roux-en-Y gastric bypass at 5 years of follow-up. So the number of patients in this study is large. So we must keep in mind that laparoscopic gastric sleeve is good option also for obesity and for metabolic problems. Let's say gastric sleeve is good surgery for resolution of diabetes type 2. When you look some newest data from literature, there is a systematic review of meta-analysis of some authors when we found they found that resolution rates in diabetes is also both good with Roux-en-Y and laparoscopic gastric sleeve during 5 years of follow-up. Next, this is my patient. In the one of the first patient, you can see let's say neofundus. No, it's not a good resected fundus and sleeve. So large sleeve is not good surgery. I operated on this patient again and do gastric sleeve. And when you look in the literature, also laparoscopic sleeve gastrectomy is a promising option for failed weight loss after laparoscopic gastric sleeve in patients who demonstrate the presence of a large gastric pouch. So we must keep in mind that we must do a good sleeve resection. You can see some early picture about how to do a sleeve gastrectomy, and you can see on this slide, this is a whole antrum left in gastric sleeve procedure. Is it good? Okay. When we look in literature, also from there is a story about let's say about 2014. Is it possible to make a subtotal atherectomy and also let's say radical atherectomy in gastric sleeve? And some authors conclude that sleeve is a safe and effective procedure with good short-term outcome, and increasing the size of the resected antrum is associated with better weight loss without increasing the rate of complications significantly. It was in 2014, and newest data from 2020 performing the laparoscopic sleeve gastrectomy with a radical atherectomy could improve weight loss at 12 months follow-up, but exposed to lower food tolerance and higher transitory GERD, gastroesophageal reflux disease. We heard about something about in the beginning of this session. But the differences seems to be reduced to a 40-month period. Preservation of antrum in gastric sleeve does not change in gastric emptying data about when we look in high resolution manometry, and we found that this is authors from Australia, that repeat esophageal peristaltic contractions induced isobaric pressurization of proximal stomach, thus providing the drive to pressurize and empty the vertical compartment of the gastric sleeve. Transit following sleeve gastrectomy appeared to be esophageal mediated and followed by distinct cycle with strong association with esophageal reflux. So if you leave antrum, don't expect that transit from to duodenum will be better, because esophageal motility push food and swallow in duodenum without antrum. Also, in this moment, we must think about long life period when someone go to an operation. You can see a lot of our patients have a diet, and if they go in bariatric surgery, they have some problems with hormonal disturbances, and they lose their weight. But during a greater understanding of this procedure, will allow to surgical procedure of choice to be tailored to the individual to maximize post-surgery health outcomes, and will facilitate the discovery of non-surgical treatments for people with obesity. We see our patients, and we must tell our patients, don't expect that one operation will solve lifelong your obesity and metabolic syndrome. So we must keep in mind what is the best solution with lower complication rate, with easy for patient and easy for surgeon, how to do that. So I think laparoscopic gastric sleeve gastrectomy must be kept in mind as the first choice. Second, I can show you some pictures of 2 days ago. I operated one patient with sleeve. You can see clear dissection of pyloric region. Of course, adhesions must be resolved. Good mobilization of fundus, and you can see this gastric pouch. And then I push probe bougie, but it is actually 36 or 36 French, and we pass in duodenum through the pylorus, and after that we put first stepping very near pylorus, maybe less than 2 centimeters, and then we make resection of, you are familiar with this, and of course fundus must be resected. You can see all this, and you can see antral resection, body and fundus. But I must tell you, if you want to make a good antral resection, you will be faced with some serosal tears here, and I always in this situation I make some suture with V-lock, and I suture this. So this is a sleeve, no buttressing material, no overlapping, because I don't think that we have too much space to have some stitches. And then we always make some control with let's say maximum 50 milliliters. This is a 30 or 40 milliliters, and you can see the sleeve is full, and it's a very good sleeve, let's say. And this is resected gastric. You can see, let's say, J. A lot of people now tell in literature that it is a J type of gastric sleeve, and of course drainage. Okay, when we faced with surgery after gastric sleeve, sleeve gastrectomy has significantly lower risk of reintervention in all categories. It's data from this year and later. But of course, if we have a problem or failed sleeve or some other problems with sleeve, like gastroesophageal reflux disease, or twisting, or not sufficient control of metabolic disease, then after sleeve we can do a lot of procedures. Of course, rising procedures, MGB, OAGB, also BPD, DS, SADS, Roux epsilon bypass, transit bipartition, or let's say some other malabsorptive procedures. Then, in conclusion, I must say that gastric sleeve, we must thinking about gastric sleeve as a first choice in most of patients who suffered of obesity and metabolic disorders, but we have to done properly. Thank you very much. Okay. Okay.
Thank you, Miroslav. It is always very important. You always keep in consideration and take always in your professional life training to young people and education. And this is right, because of course it is a very important part of our professional activity to train appropriately young people, and this kind of reflection, observation, and presentation are fundamental for them, as well as you described the evolution of the technique in sleeve gastrectomy, because of course we have been I started doing sleeve gastrectomy in 2002, almost 20 years ago, but that was the first stage of a duodenal switch. And now we do a different operation, and the operation is evolving. It is evolving in terms of volume reducing capacity. So we are trying to resect as much volume of the stomach, and as also all of us, we know we need to resect the fundus for a number of reasons, for the ghrelin and for the dilation capacity of the fundus. So, and the antrum, I think you pointed out very nicely, the antrectomy is becoming an important step. It's the first, the start of the sleeve is from the amount of antrum you resect, taking into consideration the incisura angularis, of course, to not create kinking. So I think your presentation was very well received, very nice, and I think we now move